Group is technically our first meeting of the 2023 session, even though we have met 2 times previously in concert with the House. But today we have several reports we're going to hear. We will not be acting on any legislation, but very pleased to have everyone here. But with that, let's do the roll call, please, Becky.
Senator Rocky Adams, Senator Berg, Senator Carroll, Senator Funky Fromeyer,
Present.
Senator Nemes,
Present.
Senator Tishner,
Present.
Senator Wise, Vice Chair Douglas,
Present.
Chairman Meredith.
Present. Again, we do have a quorum. We will proceed, but before we do, does anybody have any introductions they would like to make? If not, please allow me to introduce my legislative intern for the day. She's sitting to my far right over here. This is Dolores White. She is the current president of the Kentucky Nurses Association. So if you would, please welcome her to our meeting. Anyone else? If not, let's proceed with our first report. Again, our intent today is just kind of bring us up to speed on some things that we're going to be working on. No action on bills today. With that, first report is on maternal mental health. And I believe we have Dr. Jeffrey Goldberg and Abby Piper here for the presentation. If you would, please introduce yourself for the record and feel free to proceed.
Good morning. Thank you, Chairman Meredith. I'm Dr. Jeff Goldberg. I'm here today on behalf of the Kentucky section of the American College of Obstetricians and Gynecologists. We represent OBGYNs throughout the state as we try and advance maternal health care. With me today is Abby Piper from Piper Smith, our lobbying firm. They help us advocate. I want to thank you for the opportunity to give an update on maternal morbidity and mortality and some of the work that's been going on since we last testified before the committee. And I'll give you the spoiler right up front. We're going to be talking a lot today about maternal mental health and how it's impacting maternal mortality in the state of Kentucky. This is something that is really the overriding focus of what we do in obstetrics and gynecology. A lot of people think of a visit to an OBGYN as I'm checking to make sure the baby's okay, and some of that is true. But really we're focused on how do we keep moms healthy, because if you want a healthy baby, you've got to have a healthy mom. Fortunately, we've made tremendous strides over the last century. If I can have the next slide. Some of you have seen this slide before. If you go back a little over 100 years, say to when my grandmother was born in 1908, your chances of dying from a pregnancy-related complication was almost 1 in 100. Pretty much everybody knew of somebody who had died from pregnancy or somebody who had lost their mother in childbirth. And fortunately, with modern obstetrical care, we've seen dramatic reductions in those maternal mortality rates over the last 100 years. The advent of things like blood banking and antibiotics and improved surgical techniques led to dramatic drops in the 40s and 50s. And by the time I went to medical school in the 1980s, maternal mortality was exceedingly rare. There were some states that would go a whole year without a single maternal death. So why are we still having this conversation? Well, unfortunately, over the last 30 years, and the next slide, the maternal mortality rate has been going back up. Now, it's still nothing like what it was when my grandmother was born, but we're seeing consistent rises over the last 30 years in spite of the advances that we've seen in medical science and in spite of the fact that in the U.S. we spend more money per person on health care than any other country. And unfortunately, we now have the worst maternal mortality rate of any of our peer-developed countries. In fact, we're 55th in the world. We have a worse maternal mortality than Russia, than Albania. We're behind Tajikistan. If you're 25 years old and pregnant today, you have a higher chance of dying from your pregnancy than your mother did when she was pregnant with you 25 years ago. And I don't think I have to convince anybody here that that's completely unacceptable. Next slide. If you're wondering if this applies to Kentucky, we're basically in the middle of the pack. If you look at Kentucky's maternal mortality rate, it's going up pretty much in step with the rest of the country. Next slide. So the number one question I would get when I showed people those slides is, why is this happening? And 5 years ago, my answer was always the same: we don't know. And the reason we didn't know is nobody was collecting data on these maternal deaths, why they were happening, what could potentially prevent it. The other question I would often get is, even though the rate's going up, fortunately maternal deaths are still relatively rare. So why are we focusing on maternal mortality? Aren't there other things we should be working on? And the answer is because maternal mortality represents the tip of the iceberg. It tells us where we should be focusing our efforts to improve health. Our best estimate is that for every death from a specific condition, there are probably in the neighborhood of maybe 70 other patients who had the same condition, had severe morbidity, fortunately didn't die from it, but might have. And even though it didn't turn out to be fatal, they're often left with ongoing severe health consequences. It impacts their ability to take care of their infant and other children, other members of the family, impacts their ability to work, significant financial toxicity. So when we talk about reducing maternal mortality, yes, we're talking about preventing maternal deaths, and that's critical, but we're also really looking at how do we reduce a significant amount of morbidity in the process of doing so. So how do we get started with this? Well, first of all, you have to know what you're dealing with. If I don't know what the nature of the problem is, I can't come up with solutions for it. So an initial step is to form a maternal mortality review committee, and I'm mentioning this specifically today because I want to thank the legislature for making this happen. 5 years ago, House Bill 167 was passed by the legislature, enabling the Department for Public Health to create a maternal mortality review committee. And I cannot emphasize enough how critical this has been. Had that legislation not been passed, I could not be sitting here today giving you this report. So for those of you that were involved in passing that bill, again, thank you for your efforts. Why is an MMRC so critical? Again, we can't manage what we're not measuring. If I don't know what we need to be dealing with, I can't change the nature of that curve I showed you. The good news is that we've demonstrated that if you can figure out what's going on, you can, in fact, reverse the trend. Next slide. The best example of that in this country has been what's been done out in California. About 15 years ago, California looked at the rising maternal mortality rate, said this is unacceptable, formed a maternal mortality review committee. They found that obstetrical hemorrhage was by far the leading cause of excess mortality, women who were bleeding to death from delivery or complications from pregnancy. This wasn't because we didn't know how to prevent it from happening. In fact, the medical science and the tools that we have to stop bleeding, the new surgical techniques are better than ever. The real problem is that those techniques weren't being applied consistently for all women in all institutions in California 100% of the time. So California developed a checklist, if you will, a protocol for how to manage obstetrical hemorrhage, both prevention and management. They distributed that protocol throughout the state, and most importantly, they formed a support network involving every institution in California involving obstetrical care. And through those efforts and the implementation of those guidelines, they were not able to reverse the increase. They actually got their maternal mortality rate down to less than half of what we're seeing in the rest of the U.S. So we know that this can be done. Why don't we just take what California did and apply it to Kentucky? Well, at the risk of stating the obvious, we're not California. It's very important that we be able to examine maternal deaths in Kentucky because, not surprisingly, the nature of those deaths are very different than what they had in California. The Maternal Mortality Review Committee has only been in operation for a relatively short time. Again, the legislation creating it was just passed 5 years ago. But we are starting to get some data out of the committee that's been very informative, and that's what I want to talk about here today. First of all, it's important to note what wasn't found by the committee. The committee was not finding a lot of maternal deaths from obstetrical hemorrhage or preeclampsia or infection or any of the other conditions that historically have been a major cause of maternal mortality. I would speculate that that's probably because Kentucky has absorbed the lessons learned in states like California. The paradigm that's been put forth by California is in routine use today around the state. So we've tackled a lot of what historically have been major problems. What has been found is that maternal mental health is playing a major role in maternal mortality in Kentucky. Again, this work is preliminary. There's still a lot of data yet to be analyzed, but there are some things that are important to share here today. First of all, the committee has found that at least 8.5% of maternal deaths are due to suicide. I say at least 8.5% because Kentucky has very strict criteria for what qualifies as a suicide to be listed on a death certificate. It is very likely that many deaths that were listed as accidental, particularly those involving substance use, probably had a component of self-harm, but that's very difficult to analyze. So I don't know if the real number should be 10% or 15% or what it actually is, but it's clearly very significant. And just to underscore that, if you evaluate the population of Medicaid patients who've given delivery and look at those who've required readmission to the hospital in the first 3 months after delivery, historically we've seen readmissions for infection or late onset preeclampsia or sometimes heart failure. That's not what we're seeing in Kentucky. The number one reason for readmission in Kentucky among our Medicaid patients is suicidal ideation. So clearly this is a major problem that needs to be addressed. Another finding from the committee, to no one's surprise, is that we're seeing a great deal of substance use disorder, which again is a mental health issue. They found that substance use disorder was a contributing factor in at least half of all maternal deaths. In fact, it was possibly a contributing factor in as many as 2/3 of maternal deaths, and this is mirroring what we're seeing in the non-pregnant population. One of the assessments done by the committee in reviewing cases is looking to see if the death was potentially preventable. There are certain conditions in pregnancy that unfortunately medical science does not yet know how to consistently prevent or effectively treat. They're rare, but they do happen. So we probably can't get to the point with today's technology where our death rate's going to be 0. But on reviewing these cases, the MMRC found that 90% of the maternal deaths that they evaluated were potentially preventable. To me, that is a shocking statistic. 9 out of every 10 maternal deaths need not have happened if we had the right systems in place. And I hope that gets everybody's attention. That is a tremendous opportunity for improvement. Next slide. So now that we have this data coming in, what's being done? Fortunately, we have some folks in the Department for Public Health that are very dedicated, very much on top of this. They oversee the activities of the MMRC. They are responsible for taking this information and coming up with action plans. In the interest of time, I'm not going to go through everything that they're doing about this. I would refer you to the CHFS website. There's an excellent maternal mortality review report that you can read. But I do want to highlight one of their key activities that has been undertaken in the last few years, and that's the formation of a perinatal quality collaborative, or what we call the Kentucky PQC. And this is something that is going to directly affect your constituents. PQCs are cooperative groups that are found throughout the country. They are formed with multiple stakeholders who work to improve maternal and neonatal care, and it includes health providers at all levels. It includes healthcare institutions that provide obstetrical care. It includes insurers. It includes professional societies like ACOG, national societies like the March of Dimes. Although it's a national program that's overseen by the CDC, it's done at the state level. So each state has to set up its own PQC, and we've had one since October 2019. I would encourage you to take a look at the work that they've been doing, particularly around maternal mental health, including substance abuse. The website is kentuckypqc.org. Again, I'm not going to go through all the details, but I would encourage you to take a look at that. It's a very robust program. They have Zoom web conferences every other month on these topics. There's a conference call every other week assisting institutions in implementing recommendations. So it's been very active. Next slide. Now, when you see this data, again, I think some of it is very compelling that we need to do something, we need to do something quickly. But it's important that we step back and be careful about what exactly we do. Number one, we need to make sure that any efforts we're undertaking is something that's directed by an analysis of the data. There's only so much bandwidth for interventions. We want to make sure that everything that we're doing is evidence-based, meaning that there's clinical studies that demonstrate that it's actually effective. There's often a temptation to implement ideas that sound good. And unfortunately, the history of medicine is replete with ideas that sounded good, but then when rigorously tested, turned out not to be effective or in some cases even harmful. The other thing that we want to avoid doing is trying to throw rules at the problem. It's very often that we'll look at something and realize that problems are occurring because people aren't doing something they're supposed to, or they are doing something they're not supposed to, and we create a rule that says don't do that, and then we say, okay, we're done. And unfortunately, that doesn't really solve the problem. There are exceptions. There are some rules that are truly impactful. For example, the law that says you have to wear a seatbelt when you're driving a car has saved a lot of lives. But that's really the exception. What we really want to focus on is not making more rules, but improving the system in which we deliver care. The idea, as I give a lot of these talks, I tell people we're not trying to get people to follow the rules. We're trying to get people to want to follow the rules. And that's a complex endeavor, but that's the only way that you can move the needle. One of the programs that the Kentucky PQC has at its disposal as we're trying to improve these numbers comes from an organization called the Alliance for Innovation on Maternal Health, or AIM. AIM is a national organization that was formed by ACOG and has 22 partners. It's a national level program to reduce maternal morbidity and mortality, but even though it's a nationwide program, it's implemented at the state level. Every state has to apply to participate in the AIM program. There are certain requirements for participation, including having an MMRC and having a PQC. And now that Kentucky has those things, we are now an AIM state. And again, I would encourage you to look at some of the specific measures that are being promulgated through AIM. Their website is easy to remember. It's saferbirth.org, and I would encourage you to check that out. One of the many tools that AIM puts at our disposal is what are called patient safety bundles. Again, there's no lack of science as to how to deal with various problems like preventing death from hemorrhage or a death from infection. The difficulty has been how do we get institutions to apply all of these effective things with every patient, in every location, 100% of the time. That's where the gaps are, and that's why we're seeing the maternal mortality that I've showed you. One of the analogies I use is if you imagine a landing checklist for an airplane, it's not okay if you just do most of the things on the checklist. You don't get points for doing some of it. If you don't do everything on the checklist, with every airplane, every flight, you're going to see airplanes crashing. It's the same in healthcare. We need to make sure that everybody gets exactly what they're supposed to be getting 100% of the time. So AIM has developed what we call safety bundles. This is groups of care plans that are appropriate for every patient for various conditions. The first ones that were developed were for some of the historically more common problems like hemorrhage or infection or dealing with preeclampsia. Again, those are not things that we're seeing as much of a problem with in Kentucky. Fortunately, we have newer AIM bundles that you see at the bottom of the screen, including perinatal mental health and substance use disorder. And that last one is going to be the primary focus of Kentucky's PQC as we move forward. Again, if you want to see some of the details of what goes into these bundles, I encourage you to check out the saferbirth.org website. The nice thing about having these bundles available is we don't have to reinvent the wheel. The science, what needs to be done, has already been established. The materials that you need to do it are available to us. The action plan for how do you get this consistently implemented through all the institutions throughout your state, how do you work through your PQC to make sure that these things are happening, that roadmap has already been developed. So the folks at the Department for Public Health don't have to redo that work. They just have to take it and run with it through our PQC. I threw this poster up there just as an example of some of the many materials that are available. This is a poster that's designed for healthcare providers who are not obstetricians. This might go up, for example, in a triage room or an ER or a family practice clinic. And it's a reminder, a checklist, if you will, of some of the warning signs to check for problems related to pregnancy or postpartum that could potentially be fatal, things that we don't want to miss. And included on that list are symptoms of postpartum depression. So there are many, many materials like this available and are being pushed out by the Department for Public Health. So what can you do to help? Well, first of all, you've already done a lot of it. Just creating the MMRC has been a very critical step. None of the work that's going on now could be happening without that data from the MMRC, and it's going to continue to yield significant data going forward. So again, for those of you that were involved in that effort, I can't thank you enough. Just having this hearing today and addressing this problem and raising awareness is also a major step. I would note that what we're doing now is happening on a voluntary basis. We're very fortunate that we have personnel in the Department for Public Health who are doing a phenomenal job of instituting these programs. They're very dedicated people, they're very talented, but they're not doing it because they're fulfilling a statutory requirement. They're doing it because it's the right thing to do. But our state's participation in the AIM program is voluntary. Participation of various institutions around the state in the PQC program is voluntary. It's been fairly robust. We have over 70% of institutions that provide obstetrical care participating in the program, and they've identified at least one person in their institution who's responsible for making sure that these PQC initiatives get implemented in those institutions. But that number needs to be 100%. And I would hope that the legislature can make clear that they are supporting the efforts of the Department for Public Health in trying to move the needle and improve maternal morbidity and mortality. And right now that means focusing on maternal mental health. Participation in these programs should be mandatory, not voluntary. And we need to make sure that we're giving the Department for Public Health the resources and the support that they need to carry out these programs. So with that, I'll stop and take any questions. I want to thank you again for your time this morning. Happy to answer any questions.
Thank you, Doctor. And first comment I would have, not a question but comment, is I just want to commend you. You've become a committee rock star because you kept this to 20 minutes like I asked you to, and that's the first thing I heard of. So I thank you. We are going to dedicate about 5 minutes to questions. And I guess another comment on your slide about next steps, you said avoid additional statutory mandates and regulations. You do know this is state government, right? Senator Berg, you have a question, comment?
I do have a question, sir. Thank you very much, and thank you for a very interesting presentation. Have we looked at maternal mortality have we broken it down to see if we have what the degree of racial disparity in the state is?
That data hasn't been published yet, but yes, it's being looked at.
Is it available to share?
Not through me. The Department for Public Health has that information, but they're also, they're very careful about making sure that they're releasing accurate data. So it's definitely being looked at. There's a strong focus on social determinants of health, including income levels, racial disparities, and so forth. So absolutely that data is being looked at. But again, I want to emphasize we're very early on in this process. Although 5 years might seem like a lot of time, it takes a certain amount of time to assemble that committee. It's a very large committee because we want to make sure there's representation from every healthcare discipline, from non-healthcare providers. We want to make sure that there's an effective system for reviewing these cases. So they're really just getting started with that work, but at least there's a pattern for looking for all the data we need to know, including what you asked about, racial disparities and so forth. So they're working very hard to get caught up to present day. They're going back and reviewing cases from 2017 forward, I believe, and they're through 2018, but there's really several more years of data you need to look at before you have a large enough sample size to give you good quality data.
Thank you.
Yes,
Senator Monkey Frommeyer. Sorry, can't get my mic working.
thank you, Dr. Goldberg. So much great resources and information. And I wanted to just take a quick privilege. The pursuit of midwifery and maternal wellness. One of my constituents is here today, Meredith Strayhorn, and thank you for being here. What I wanted to ask you, Dr. Goldberg, when you suggested that improving the system of care, there was a House bill filed the first of this year by our majority caucus with Jason Nemes, and then I filed a companion bill to that yesterday on expanding birthing centers. And I see that as a yes, and that yes, we have wonderful hospital opportunity with great outcomes, but we also could see great outcomes and have seen throughout the nation in birthing centers. Do you see that maybe falling nicely in line with the improve the system of care that you're asking us to represent as legislators?
Yeah, absolutely. Basically, every facility or program that is involved in providing health care for pregnant women needs to be part of this process. If you look at who's involved in the PQC, it's healthcare professionals at all levels, institutions at all levels, again, insurers, national organizations, and including both professional midwives and certified nurse midwives. Everybody has to be at the table. Birthing centers are a component of obstetrical care in the United States. They are an option for where to give birth, and they absolutely need to be part of the process of making sure that we are bringing all the tools necessary to help prevent morbidity and mortality. So if Kentucky does have a new birthing center, they will absolutely be invited to be part of the PQC, and we hope will be a big component of these efforts.
I needed one more privilege, Senator Meredith.
Briefly, please.
So I'm the 6th of 12. My mom is the 3rd of 17, and I'm a mom of 6 and a nana of 5. So I did get to see the nurse midwives in practice on the 4th of our grandchildren, born only a year and a half ago. So very excited for this holistic approach and the perinatal quality collaborative. Great work. Thank you.
Last
you.
question, comment from Senator Douglas.
Dr. Goldberg, I don't know if I have a question in this or not, but I certainly, in taking a look at the data and the information that you've presented, I just kind of want to sum this up, at least for me. We're seeing increased maternal mental health issues, and we go on and ask if the legislature will support this, and obviously that is what our people elect us for, is to serve our constituents. But I want to dive a little bit deeper into this, and we talk about 8.5% of the mortality can be related to suicide. Then we go on to talk about how 2/3 of those deaths, or 2/3 of the deaths related to maternal mental health, are actually associated with substance abuse disorder. And for me, as a physician as well, that takes me to a different area, because one of the comments I've often made is that mentally healthy people make poor decisions. And substance abuse disorder, the entrance into the substance abuse disorder, I don't want to equate poor mental health with the entry or the pathway into substance abuse disorder. And I think sometimes in our society we do that. And I don't want to do that. I know there are some people who enter through that portal, but I also don't want to make excuses for people who make poor decisions. And I know this won't play very well, but that's not why I got elected. I don't want us to miss the boat and hold our providers and our healthcare system responsible for some of the poor decisions that people make. We can do what we can do on our side as a provider, or the people who run health institutions, to help people. But somehow we've got to really address the continual poor decisions and the poor environments that people find themselves in without a very good support system. And I just don't want to mix up providing poor health care with having an inadequate support system. And I think often, and I think you would agree probably if we weren't in this room, that happens. We hold another system accountable, but another system is responsible. So I guess I would quickly, I just quickly want to make that distinction so that we can adequately attack this problem. Because as long as we hold our healthcare system responsible for decisions that we have no control, for decisions that other people make for which we have no control over, we're not going to get a handle on this. We can spend all the money we want to spend, but we just won't get a handle on it. And I guess the question is, how do we help our patients become more responsible decision makers in this equation? And I get the smile. Right. Believe me, I've been there. I get the smile.
So as the two doctors in the room, certainly we struggle with that every day. How do I get my patient to do the right thing? And that is probably what I spend most of the visit doing. And just so everybody knows, I'm actually a cancer specialist. I'm a gynecologic oncologist. I'm not an expert in substance use disorder, but there's no question a big chunk of our time is spent convincing people to take the treatments that's best for them. And that's really the art of medicine. There's the science. I can tell you what the best treatment is for your cancer, but convincing you to take it is another story, or helping you to make decisions when there are choices to be made. So unfortunately, I don't think Dr. Meredith or Senator Meredith is going to allow us the time to have that conversation. But yes, you do raise an interesting point, which is we follow the data. We're looking at what are the causes of maternal mortality in Kentucky, which of those causes are preventable, which again, 90% of the time it is. And then we start asking, how do we do that? There is a component of what was the etiology of it, because yes, we'd rather prevent a problem in the first place than have to manage it once it occurs. But either way, we can't ignore the fact that there's a large number of deaths that are due to mental health conditions, whether it's depression, pre-existing depression, postpartum depression, substance use disorder. All of these things are potentially preventable deaths.
And Senator Douglas, if I may, obviously we want healthy mommies, healthy babies. And so, any of those layers that kind of overlap into that work, we'd be happy to talk more about.
Certainly a great presentation today, and this is not the only time we'll be having this dialogue with you through the session, and probably over the next 2 or 3 years. Probably of everything you said today, what impressed me the most was the fact that 90% of these deaths are preventable, and that certainly is a challenge for us. So appreciate your presentation today. Look forward to our continued dialogue on this, and I'm sure committee members will be talking about this in more detail. So again, appreciate you being here. Thank you.
Thank
we
you.
can move on. Our Medicaid annual report is the next presentation we have. And we have Commissioner Lisa Lee, another committee rock star. The reason we asked Commissioner Lee to be here today, she's going to present a Medicaid annual report, which is a new report for us. And just a reminder to the committees that before we reconstituted this committee to become health services, we had a separate statutory committee, Medicaid Oversight, which would hear those reports and take appropriate action when we could. So now this has been incorporated under our responsibility. So since this is a new report, which you will be receiving hopefully on an annual basis in the future, I want Commissioner Lee to kind of give an overview of this and talk about what we can expect in the future. So Commissioner Lee, if you would identify yourself for the record, and please proceed.
Good morning. I am Lisa Lee. I'm the Commissioner for the Kentucky Department for Medicaid Services, and very happy to be here to talk about the Medicaid Annual Report. The Medicaid Annual Report is not a unique idea. Many state agencies have Medicaid Annual Reports that they present each year. They even have websites that they post those reports on. So what we did in the department is we went out and looked at several of those reports to try to see how could we develop a Medicaid Annual Report for Kentucky? What information would be useful? So this is the very first comprehensive report. But most of the data in this report is available in other places. We've just compiled it in one area to try to give individuals just a big, broad overview of what's going on in the Medicaid program. We have created it to share information. We want this first annual report, which is 2020. It's a little dated, but it did take us a while to pull the information together. But the good news is now that we have this first annual report, we can plug information in it a lot quicker, so we should get the next 2 iterations out sooner. It does provide a very high-level overview of the program, and it is, again, for state fiscal year 2020, which is July 1st, 2019 through June 30th of 2020. The table of contents tells you pretty much everything that's in the report. We did have to do some technical notes. We found this, I think, in Louisiana's annual report. Because the Medicaid program is so complex, we have to have some information in there so that individuals know kind of what they're looking at. So, for example, if you pull information based on a paid date of service versus the date the service was actually delivered, you're going to get 2 different reports. So some of that information is in the technical notes. The background information just gives you a historical overview of the Medicaid program in general. We have an agency overview of the department and where it stands within the Cabinet for Health and Family Services. We have a listing of all of our technical advisory groups. We have about 22 technical advisory groups that report and work with the Department for Medicaid Services, and they report up to a Medicaid Advisory Council. This is a little bit unique for Kentucky. Typically, state Medicaid agencies have a Medicaid Advisory Council, and they have a variety of representatives on that council, including legislators. In Kentucky's, ours works just a little bit differently with those 22 advisory groups. We also talk a little bit about the public health emergency due to COVID, because when we started the report in 2020, we had to incorporate some of that information in there. We have the 2020 year in review, just talking about how many individuals were enrolled in the program, where they were at. And just we have some programmatic changes, policy changes that we implemented in 2020. So as we go forward in 2021 and 22, you'll see other policy changes that we made, such as Senate Bill 50 with the single pharmacy benefit manager and some of the impacts that had on the program. We have a breakdown of eligibility by county. We also have a 5-year countywide change in eligibility that is very telling. We talk a little bit about our Medicaid providers, and if you look at the report, you'll see, for example, we have listed 886 hospitals. Now, we know we don't have 886 hospitals in Kentucky, but we do count out-of-state providers. So a lot of our surrounding states, we have hospitals. Sometimes we will have members who are out of state for one reason or another. If they have some sort of an accident, for example, and they have to go to a hospital, we will work with those other state hospitals to enroll into the Medicaid program so that we can bill for those services. We show, outline a little bit of the services that we provided, some of the top diagnosis codes and top procedure codes. We break this out by fee-for-service, which mainly includes individuals who are in home and community-based waivers or in long-term care facilities. We also have a breakout of managed care organization services, because managed care organizations serve about 90% of the Medicaid population in Kentucky. We have some key prescription statistics in the report, a little overview of the finance, including state budget and federal dollars that come into the program. And of course, it wouldn't be state government without an acronym. So we do have a very comprehensive acronym list in the back of the report. And then the 5-year county enrollment changes that I spoke about earlier. And then we also have a list of the top providers who are delivering services to the Medicaid members in Kentucky. Some of the notable content is the enrollment by county with an outline of percentage of who receives services and the total dollar amount paid per county. So you can look at this report and see in a county how many individuals were enrolled in Medicaid in that county, and of those individuals, who actually received a Medicaid service that was paid for during that reporting year. We have the 5-year enrollment trend by county, so you can see individuals shifting between the counties if the county enrollment in Medicaid is either increasing or decreasing. Again, we have the child versus the adult comparison related to diagnosis codes and procedure codes. We do compare the fee-for-service and managed care members as far as diagnosis, procedure codes, and medication. And when you look at these charts, you can definitely see a stark difference in the Medicaid fee-for-service population versus the managed care members and the services that they receive. We also have the enrollment by managed care organizations where our enrollees are choosing to get their service from the managed care organizations. And then again, the number of providers, including out of state. This map is also included in our report. This is a report of and you can see since 2016, enrollment has increased in our Medicaid population by about 34.9%. This is a report by county. As you can see, the red counties have more individuals enrolled than those counties shaded in blue or brown. So our enrollment demographics, you can look at this and see half of our enrollees are female and male. We have a pretty good breakdown. We have about 37% of our children, our enrollment are children. Elderly account for 6.8%, and adults are 56%. The adult population would include blind individuals, disabled, and pregnant women. You can see from our race and ethnicity demographics, about 11% are African American, 20% are other or chose not to choose chose not to select that demographic on their application. And again, that is something that is not mandatory in the Medicaid program. When you apply for Medicaid, it is not mandatory that you check race or ethnicity. So we have a little breakout here by payments and enrollment by age group. You can see that while elderly individuals account for about 6% of our population, they account for about 15% of the payments. Same way, if you go down the chart, you can see that the adult waiver population, which again are those individuals in home and community-based waivers and long-term care facilities, about 1% of our population, but they account for about 10% of the costs. Now, we can compare that with the members and payments ranked by payments. This demonstrates that of all of our members, if you group them, for example, if you look at the gray shaded area, those are high utilizers, mid-high utilizers, and it shows that about 20% of our population accounts for over 84% of our costs in the Medicaid program. So you can see that approximately half of our program in that bottom dark blue box, 50% accounts for about 3.9% of our payments in Medicaid. So to break this down a little bit, I think that this is one of the great things about getting this information and getting it in a comprehensive document that you can look at. So when we started looking at this information, we said, can we see, for example, who are those high-cost utilizers? So we noticed that we have 23 members in the Medicaid program out of the 1.5 million that we served in 2020. 23 of those individuals, we paid over $1 million during that year for their services. So we wanted to see what's happening. Who are these individuals? And I have been in Medicaid for over 20 years, so I automatically assumed that I knew this would be waiver individuals or individuals in long-term care. It was not. These are individuals. We had some NICU babies in there, several NICU babies. We had some hemophiliacs. So if we look at this, I think this is very important for us as we move forward in the Medicaid program. We can identify some of those areas where we think we can make a difference and where we can't make a difference by amending our policies. And again, that's one of the reasons for this report, is to give information to individuals who are interested in the Medicaid program and who have a stake in the Medicaid program to ask questions. So for example, the report that was just given before us about maternal mortality and the Medicaid rate of readmits, I would think that one question that either this body or that our Medicaid Advisory Council should ask is how many members in the Medicaid program, how many pregnant women after they delivered had to readmit into the hospital in 3 months, in 6 months. Of those, what region were they in? What hospital did they deliver in? Is one hospital doing better than the other, and what can we learn from that information? Because if you look in the report, you can see that one of the top diagnosis codes, procedure codes that we do is we deliver babies. We pay to have babies delivered. Medicaid pays for over half of the children born in this state. So combining those two reports together, that would be, to me, a really good question to ask is what's happening in the Medicaid program with maternal mortality. We do have a lot of focus on that. We are working with the Department for Public Health, but again, that one question of how many readmits in Medicaid, I don't know that that information is out there, but if it is, it's a good question to ask. So if you go down through this report again, you can see that we had 638,411 members that we spent less than $1,000 per year on in 2020. So again, just good information to know to kind of help focus our attention on where we should be looking at policies for the Medicaid program as we go forward. So again, going forward, we want to use this 2020 report as a benchmark. We can produce future iterations, I think, at a little bit quicker speed. We want to distribute this information to individuals and organizations who are interested in the Medicaid program and to whom we talk on a daily basis. We want this information to drive those conversations around healthcare policy. And we want to definitely promote transparency. So again, this is just the first iteration of the Medicaid report. Very interested in what this committee thinks, what you would like to see in future iterations of the report as we go forward. Would it be very helpful to have a breakdown or some information of emergency room visits, for example? What are the diagnosis codes or procedure codes in emergency rooms? So again, very interested in this committee, what you would like to see in future iterations and how we can best use this information to drive those positive policies that drive our health care. And I'm happy to answer any questions or have a discussion about anything in the report.
Commissioner Lee, I appreciate you taking the initiative on this, a wealth of information. And I'm not going to entertain questions from our committee because this is a draft. I can envision that this summer during the interim session, we could probably hold a single meeting just on this subject, which I would encourage us to do. So committee members, I'd ask you to kind of develop your questions. We'll feed them to Commissioner Lee. We can get in this deeper dive in this summer, but I think this is a great report. You know, the only question I would have, and you kind of touched on this a little bit, is how can we use this report to truly drive policy decisions? And, you know, what comes to mind for many on this committee is the decision to extend Medicaid benefits for hearing, vision, and dental, when that really wasn't embraced by our legislature, wasn't embraced by Medicaid oversight, and I don't think health and welfare either. And why did that become a priority when we really thought that it should go to increased payments to providers or add more people that are looking for care under the waiver program? So how do we use this document to drive policy? And how do we develop this symbiotic relationship where we make these decisions jointly rather than just unilaterally, like was done with the decision to add additional Medicaid benefits?
And I think this is the first step in great conversations that we can have based on actual data. I think the previous presentation too, some of the takeaways that I got was definitely using data to inform our decisions as we move forward, and look forward to working with this committee as we develop a healthier Kentucky, because we are definitely all here for the same reason, and that's to improve the lives of those we serve. And Senator Funky Fromeyer, I have to say I'm the youngest of 13, so I think I have you beat.
Well, it's not a competition, ladies, okay? Appreciate your presentation. We will talk more about this during this summer. And one of the commitments I made to this committee is this train runs on schedule. We arrive on schedule, so appreciate your time. And with that, we'll move on to our next agenda item, which is our Minority Health Equity Report. Good morning.
Good morning.
Gosh, it seems like it's been forever since I've seen you.
It's nice to see
kind of inside joke
faces.
there. Glad to have you this morning.
Thank you.
This is my 7th session. I don't know that we've ever had a report on this particular report before, and that's why I want to get before the committee, because then as we're formulating policy, we want to know where our weaknesses are and where areas of improvement are. So if you would kind of give us a brief overview as to what this report does and maybe
Absolutely.
surmise what it tells us.
So Vivian Lasley Bibbs, Director of the Office of Health Equity for the Department for Public Health. So I'm glad to present this report. This is the first time I've actually had an opportunity to present the Minority Health Status Report. I think it contains a wealth of information, and I hope you think so too. And then at the end, I'll ask you the same thing that Commissioner Lee asked, what can we do to make the report better? Next slide. So the Minority Health Status Report is mandated by statute. It's in odd-numbered years, so I'll be presenting the 2021 report to you. It includes everything from our Kentucky Behavioral Risk Factor Study. We get data from the census, the ACS, and any other measures of population health. We get that across the information from the cabinet and information from our individual departments within public health. Next slide. So what the Minority Health Status Report does is to really highlight the disparities that we're seeing across the state and impacting Kentuckians and their health outcomes. It's a resource that we hope communities use to start conversations around what they can do to address some of the minority and vulnerable populations that we're seeing, and then really talk about those social determinants of health. And I was really intrigued by the first presentation looking at that 91% that's preventable. Some of that is the social determinants of health. Some of that is the environment that our moms live in, their social and cultural norms, those things that when they walk in the door we sometimes don't think about that are impacting the health of mom and baby. The document also provides data to support the 2021 State Strategic Plan in the Department of Public Health. So what we really talk about in the report is kind of distinguishing between health disparities and health inequities. Sometimes people get those confused. So we know that disparate health outcomes have been linked to cultural and linguistic barriers, access to services, you all can read that, finances, personal biases, and then systemic and institutional barriers that sometimes we don't often think about that are impacting moms and babies and other folks in Kentucky. So we recognize that health equity crosses many dimensions. We're not just monolithic. We're race, income, gender, our rural versus urban, the education level of our Kentuckians, the immigration status, sexual orientation, and the like. So what's actually in the report? So it's broken down into demographics, social risk factors, the health risk factors, and then health outcomes. And then after that, we list recommendations, the strengths and limitations of the report itself, and any conclusions that we have drawn from the report. So just to give you a hint of what's in the report, as far as the demographics, we break down where the majority population, 86.7% of white, and then 8% of the population Black. And then we also give the information of where those populations reside. Where do our minority populations reside? And then we also look at social risk factors, especially ACEs. We're most interested in those adverse childhood experiences. And we recognize that Kentucky is right at the top of at least having 4 or more ACEs that are impacting health for Kentuckians. And then we're also looking at some of that economic data. We're looking at that minorities are most likely renters than homeowners, and that may be important for some communities to know as they're working on economic development issues and trying to provide stable housing for folks. Next slide. Some of the other health risk factor information, we look at obesity, we look at also our disabled population, which we sometimes forget that they have health issues too. 35.1% of our disabled adults have some type of cognitive or mobility issue compared to 26.7% of the national average. And then for health outcomes, we list some of those, especially with diabetes. We look at cancer for the cancer registry. Next slide, please. And then getting to the meat of it, what's the usefulness of this data? We want it to be starting conversations, as I said earlier, but we also want it to be a point of collaboration and partnerships. We can't do this by ourselves. We need everyone to address some of these issues and understand the relationship between socioeconomic status, the intersection of those, how literacy levels and environment and policies and procedures impact health. It also lets us think about how these intertwine and exacerbate the situation. And then when we think about stratifying by race, sex, age, and other categories, how that's amplified and creates a hardship for many of Kentuckians. So what do we do to achieve health equity? Well, we need to address those social determinants of health and think about population-based interventions, evidence-based interventions, targeted methods that focus on the greatest areas of unmet need. And we need to understand the root causes of health inequities, all of those isms, ableism, sexism, racism, all of those things that perpetuate health disparities. Next slide. So this is a slide I like. It's talking about where we were, where we started, and where we need to be. So we often focused on that downstream where we just address the health outcomes. And to me, that's just putting a Band-Aid on things. I used to do clinical medicine for a while, and I used to see people come in and we'd repeat the same conversation over and over, and we'd send them out again, and we'd come back, and I'd said, I've got to do something about that. We need to start thinking about those social determinants of health, and then we need to think about some of those upstream things. What's the real issue that's impacting folks? Is it some of those structural and institutional things? Is it policies and processes that are impacting certain populations over another? So that's where this report kind of puts that question out there. What do we need to do to move forward? And I think that's where we come in to talk about targeted universalism, where that's not where we think of just because one population or community advances, something's going to be taken away from another. Targeted universalism is reaching that common goal, but how I reach it may be different than how you reach it. And that's where the targeted methods come in, that we all reach it eventually, but we all have our unique way of getting there. Next slide. So in summary, we address these health inequities so we don't keep perpetuating some of the things that we keep seeing in these reports over the years. We look at some unjust circumstances. We look at things that may be put into place that are impacting one population over the other that might need to be eliminated. And the bottom line is that everybody deserves the best health regardless of your zip code, regardless of where you live, right? Regardless of where you're in Eastern Kentucky, Western Kentucky, Central Kentucky. I'm a proponent that everybody deserves optimal health and health care. Next slide. Any questions?
Fantastic presentation, and I'm thrilled to know we have this information available to us. And as I said with Commissioner Lee's report, I think this is something definitely that we want to take a deeper dive into during the interim and really focus on those issues that we know that we can impact. So I appreciate you making this presentation. Any questions from any committee members? Dr. Douglas?
I just want to thank Ms. Bibbs for this presentation. I think the information that you're presenting is outstanding, and I really look forward to working with you more in the future.
Thank you, Senator Douglas.
Senator Carroll.
Thank you, Mr. Chairman. And just real quickly, can you talk a little bit more about with these inequities? What are the areas that we can affect the most? Is it an access issue? Is it an educational issue on these services? Is it what is it?
I'm glad you asked. The top two issues, those top two social determinants of health, are access and transportation for our state. Rises to the top every time in every community, access and transportation.
And have you all broken this down geographically to like with what was done with the Medicaid report to help us to understand, are there parts of the state that have more struggles in this area than other parts?
I'll tell you, Senator, when we saw that the most was when the pandemic hit and people finding access to get to vaccination sites, trying to get to a provider, trying to find out where they needed to go. We found out that transportation was a very big barrier for that, and also making sure that we had facilities within those communities to provide that service. So that really kind of tore the Band-Aid off, so to speak, as to where we really need to focus some of our issues in Appalachia and also in Western Kentucky. So it wasn't just in one area of the state where we saw that.
Thank you. Thank you, Mr. Chairman.
Thank you, Senator Carroll. And I appreciate that remark about not being Appalachian, Western Kentucky, but we have a tendency up here to look at urban versus rural, but we know we have those healthcare deserts within our urban areas as well. So I think that's kind of that universal view that you're talking about, is how can we make sure everybody's got a level playing field to address all these issues. So I appreciate this. I really look forward to presentation this summer. We certainly invite you back and take a deeper dive on this, but appreciate your presentation today. Folks, the last time we have on our agenda are several block grants. These are 6-month status reports. It's for informational purposes only. We will hear this again when we receive the annual report, so if there are no questions, comments, this Committee stands adjourned. Thank you, everyone, for your participation.